Fortunately, we seem to have more than half the class get on, which is really, really good. I was hoping for everybody to be able to get on, at least to record it for themselves, and review it later. But I'm doing my best to accommodate everybody here. All right, so in regards to your electrolytes, remember your hypo versus hyper. Hypo meaning low serum levels, hyper meaning high serum levels. And you've got kalemia, which is your potassium, natremia, which is your sodium, calcemia, which is your calcium, and you got your magnesia, which is your magnesium. But just look at the prefix of the word being hyper versus hypo, and that will identify whether it's high versus low serum levels. When talking about, I know we talked a little bit about immune systems, but remember, when do children generally have a developed immune system where they're no longer relying upon, what mom has given them, and they've been exposed to enough different types of abnormal proteins to kind of build this type of antibody and immune system to be more cumbersome?
Isn't it 2 years old?
Yeah, 2 to 3, good. And for those of you that have kids that went to daycare, I'm sure you remember the days of, just getting into daycare and the couple years that come after it, where it seemed like every other week, your child was runny nose, coughing, right? Had some type of viral situation that was just taken on by, a weak immune system or a poorly or not fully developed immune system to help fight all of these common virals and bacterial strands that we deal with on a day-to-day basis. When your body, what does your body do to help kind of combat pathogens or infection? We definitely release white blood cells, right? But what do the white blood cells help to promote?
Phagocytosis.
Like pyrogens
Yeah, what do the pyrogens do?
for fevers, like
Yeah, so the body tries to create an environment that the bacteria or viral strain can't survive in. So the pyrogens helps to elevate the core body temperature to help speed up the possibility of phagocytosis. Now, obviously, fevers, produce their own problems, but it's essentially trying to produce an environment that is not welcoming to these viral or bacterial strands. All right, so let's say what for patients that have edema, what are the common ways to manage edema?
Diuretics.
Okay, diuretics, good. What else?
Sequential devices.
What does that mean?
The ones that go on around their legs. It's not really pre-hospital, but hospital where they do the
Okay.
Re-push the venous blood back.
Yep. Helps with circulation for sure.
What about some minimal like elevation?
Ah, so you mean positioning?
Yeah.
Okay, yeah, positioning therapy, good. So we've got diuretics, positional therapy. What else?
Are you like asking about like medicines?
Sure, like medicines could be one. What type of medicine?
Lasix.
Okay, yep, diuretics,
Yeah.
yep.
Furosemide.
or like dialysis, if that would be the reason that they're swelling.
Okay.
pertaining-
Dialysis, good. What else?
They can like alter their diet to like have less salt because the salt bring the water.
Okay. How about we think like acute emergency management? Jesus. You guys all got great ideas, but
Well,
let's think
Or,
outside the
type-
bar here.
Well,
some type
for
of medicine.
pulmonary, you could do CPAP.
Okay, CPAP. There we
Yeah.
go. Now we're fucking on it. All right. So we got CPAP. We've got positional. We've got diuretics. What else? What's a common reason that patients experience pulmonary edema?
CHF.
CHF.
Well, that
Right-sided heart
that's
failure.
pulmonary edema. Yes.
So if we change with medication again, you change the heart. Now all of a sudden the heart's moving more, which means it moves more liquid out of the lungs.
Okay, so you're talking, but you're not
Nitro?
nitro. So you're nitrates, right? So
Right.
here we go. Let's think about common reasons why patients experience, pulmonary edema, or patients experience, edema, distal edema. A lot of times we have to consider how well the heart functions in relation to how much afterload the body is producing. And we also have to consider how much pressure the heart has to push against to circulate that blood, right? And when we're talking about, the heart has to push blood to the lungs to get it oxygenated and get it back to the left ventricle so it can go to the rest of the body, right? Well, if my left ventricle, right, maybe isn't the most proficient, my ejection fraction, okay, isn't as high as it should be, right? Because the stretch and squeeze is not as good as it once was, right? They're dealing with heart failure. The heart is beginning to fail to maintain the ability to push out enough of that percentage of blood from that left ventricle. So what does the body, from a compensation standpoint, normally do? Well, it wants to ensure that we increase that end diastolic left ventricular volume, and we release endogenous catecholamines to help to improve the inotropia and chronotropia of that myocardium, to maintain good hemodynamics, good perfusion to vital organs. So when the body begins to combat and to begin to compensate, unfortunately, these catecholamines are non-selective. They're going to create vasoconstriction everywhere, and that also means within their pulmonary vessels as well. And when I get vasoconstriction in that pulmonary vessel, it makes it harder for the heart to do what?
Pump.
Pump blood to the lungs, right? It's forcing that right ventricle to work super, super hard. On top of that, when I create that vasoconstriction, if I'm not getting more volume back to my left ventricle, although I may want to squeeze harder, right? I don't have enough volume to push against that afterload. So now I start backfilling back into the lungs. Here's where that pulmonary edema takes place. Essentially, I can't combat the peripheral resistance that's being produced by the endogenous catecholamines, and I can't combat the afterload that's being produced to help increase my preload. It's almost self-destructive in nature. So the blood pressure, right, will begin to elevate. Hypertension is what we'll see from our diagnostic tools. But because of the inability to push that blood out of that left ventricle, it's going to begin to push back pressure into the lungs, and it's going to inhibit that blood from circulating out of the lungs, and it's going to force it to pool in the tissue of the lungs, that's your pulmonary edema. So by giving nitrates, the nitrates vasodilates, right? And once again, it's it's going to vasodilate everywhere. It's going to lower the afterload, and it's going to lower the pulmonary pressures in the lungs, which is going to make it easier for that failing pump to push blood through it, right? And when we do that, the heart isn't necessarily effective in the sense where I gave a catecholamine to make the heart stronger and work faster. I just accommodated the rest of the body to accommodate the weakness of the heart. I took the pressure away. I took the back pressure away. So your nitrates, your positional therapy, sitting them up, right? Allowing gravity to allow that edema to come down. Your CPAP, right? Your expiratory pressures, which helps to expand your lungs and push that edema down, recruiting alveoli. Those are 3 common ways to improve edema patients. Now, the administration of catecholamines, it's not necessary. It's not going to be common in your bread and butter pulmonary hypertension or your bread and butter hypertensive induced pulmonary edema. The only time catecholamines come into play is when we're dealing with cardiogenic shock with congestive heart failure. So your hypotensive patients with pulmonary edema.
So what's a common drug that a catecholamine would be?
The most common catecholamine we would give in cardiogenic shock with heart failure, so essentially pulmonary edema with hypotension, would be your dobutamine. Dobutamine at 5 mics per kilo per minute have shown to not only increase the squeeze of your myocardium, but at low dosing, it helps to dilate your pulmonary vessels, which makes essentially a little bit easier for your heart to push blood to your lungs, right? And get that blood back to your heart to fill that left ventricle.
I mean, I'm looking at our drugs now, and that's not one of the ones I got under cardiac.
I'm sorry to hear
Is
that.
that one of the ones that you had?
Dobutamine it's not a common drug talked about in paramedic school because it's a synthetic. Remember, it's a synthetic version of dopamine. It's very, very similar to dopamine.
Okay, is it one of the ones that you gave us or no?
It's on your drug cards, yeah.
Is it?
Mhm.
Oh, I found it. Okay,
Good.
I had it under vasopressors. That's
So, like I
code-
said, it is going
code
to
drugs. Yeah.
at higher doses. It's going to have an alpha-1 effect. But dobutamine's main purpose in life is cardiogenic shock with heart failure, with pulmonary edema.
It says man-made dopamine.
It's synthetic dopamine. Yep.
I got it.
So, like I said, catecholamines, they're not common in pulmonary edema because most patients with pulmonary edema have hypertension, and that hypertension is fixed with nitrates versus catecholamines. Catecholamines is there's only an opportunity to give catecholamines in the event where they're dealing with cardiogenic shock and they have pulmonary edema, which is far less frequent as hypertension with pulmonary edema.
Blum, can you give me permission to record again? Sorry.
Sure. I don't think you missed much. I took a small break, so.
Perfect.
There you go.
Thank you.
Another thing you missed was when we're talking about calcium movement with carpal pedal spasms because of the shift of calcium into the cells. We have hypocalcemia in the extracellular fluid, and with hypocalcemia, one of the common symptoms is muscle cramps. So that may also present itself in somebody who is malnourished, right? Who hasn't ingested a lot of calcium, they may have hypocalcemia, and because of that, they have cramps. Type 1 diabetics, what do they need?
Insulin.
They need exogenous insulin, right? Why do they need that?
Because their pancreas isn't creating it.
Excellent. What in the pancreas is responsible for the production of insulin?
Islands of Langerhans.
Okay. And what are the 3 primary cells of the islet of Langerhans? Anybody know?
Sorry, what was the question?
What are the 3 main cells of the islet of Langerhans?
Ooh. Man, I don't know.
Was it alpha and beta and oh shit, gamma?
No, delta.
No, delta.
Alpha cells, that's your glucagon. Beta cells, that's your insulin. And delta cells, that is your somatostatin, right? So your glucagon is the safer way to store or stow your glucose, right? Convert to glucagon because glucose is narcotic. Your insulin helps to do what? Get the glucose into the cells and convert glucose back to glucagon. And your somatostatin, that's what stops the production and release of insulin. So that is that's essentially your negative feedback, right? Hey, I don't need any more insulin, right? My glucose levels are good.
Doesn't that work like if you're low on like if you're low on sugar also, that it converts it? Like in emergency situations, I remember reading something about it in there, like it'll kick it into, instead of taking it from
your glucagon converts your glycogen to glucose, right? Your insulin, okay, helps to convert your glucose back to glycogen, okay? And your delta cells stop the release of insulin. We need glucagon to convert glycogen to glucose.
So if we give a patient glucagon, like IM, that instantly gives them glucose, but it's going to burn it up really fast, right? Well, I know it doesn't give them glucose, but it allows it to release so that it can give the glucose.
So here we go. Let me ask you this. So when I give a patient glucagon, first and foremost, it does not have to be IM. It can absolutely be intravenous. We just tend to correlate it to IM because it's generally in patients that we can't get IV access with, right? So we have the ability to give glucagon IM. The patient has to have glycogen stores, right? The patient has to have glycogen to be converted to glucose, which in most cases, that's relevant. That's going to take place. The one grouping that it's not going to necessarily be a sure thing is with children. Children, because of their high cellular metabolism, they don't tend to have a high level of glycogen stores. And because of that, glucagon can be generally ineffective with children because there's nothing to convert to glucose. There's no glycogen to convert to glucose. We see this common in pediatric seizures that have hypoglycemia in their postictal state. They're tough to get IVs on. We're not as cumbersome with pediatric IVs, and we look at them like we would look at an adult. Well, I can't get an IV. They're hypoglycemic. Let me give them glucagon. But we have to think about what happens when we give them glucagon. If there's no glycogen stores, which in a kid that just had a full-blown tonic-clonic seizure, there's more than likely not glycogen stores. The glucagon is going to be ineffective.
Gotcha.
And it's not an immediate fix, right? When we give intravenous dextrose, we are giving glucose, which is why we see that rapid change in mentation. When you give glucagon IM, it's frustrating because you're hanging around on scene, right? 10, 15 minutes, your patient is still gworked in a hypoglycemic state. We get frustrated, we get fed up, whatever, we got to get the show on the road. We initiate transport, right? Because at this point, we don't know if the glucagon is going to really turn them around or not. And then we start approaching that 30-minute mark, and then all of a sudden the lights are starting to come back on, right? Their level of mentation's improving, and our reevaluation of the glucose is higher, right? The glucose levels are increasing. The glucagon is starting to convert that glycogen to glucose. It just takes time. All right. You guys fried yet? Too bad. What creates systolic blood pressure, guys?
The right ventricle.
Systolic blood pressure. What creates
Left
systolic
ventricle.
blood pressure?
Left
The left ventricle
Sorry, the
contracts
left, yeah. My
push
bad.
against the arterioles.
Good. So we have to consider the stroke volume and our what? Systemic vascular resistance, right? So the stroke volume and the pressure pushing back on that left ventricle is what essentially will dictate our systolic blood pressure. And that systolic blood pressure is what produces our distal pulses, right? So when we think, about, why we're able to palpate a systolic, or why we're able to palpate a radial pulse at an 80 to 90 general systolic blood pressure, it falls back onto, what that systolic pressure is that's secondary to what the stroke volume is for each one of those heartbeats, right? And what that pressure pushing back from that systemic vascular resistance is producing, right? That helps our preload. So just think about where these things originate from. What is the difference between viruses and bacteria? A viral versus a bacterial infection?
Viruses don't produce endo and exotoxins.
What are those?
It's the way that you're able to fight them off.
Your endo and your exotoxins are essentially what help to break down the inner components of a cell and your cellular wall, right? And that gets into like your gram negative and your gram positive bacteria. But viral infections don't produce the things that get into your cells and break them down, right? And break down your cell wall. But both viral and bacterial infections produce inflammatory responses, correct? That's what they have in similar. Difference between aerobic and anaerobic metabolism, what is it?
Oxygen, no oxygen.
Correct. Where is the breaking point when we talk about ATP production for anaerobic and aerobic?
The Krebs cycle.
Think even before the Krebs cycle. You're on the right track. Remember, glycolysis is the breaking point, right? Well, because glycolysis is simply converting the glucose to the pyruvic acid. But before the pyruvic acid even enters the Krebs cycle, there has to be the introduction of oxygen. That's why I kind of disagree with saying the Krebs cycle. But at the end of glycolysis, that is the line that separates your anaerobic and your aerobic metabolism. Because after glycolysis takes place, if there's no oxygen to convert that pyruvic acid, cellular metabolism is done. What's the difference between somatic and visceral pain?
Nerve and tissue.
When you talk about nerve, you're going to get into that referred pain, right? When I think
Visceral has to do more with the organ, a deep, dull
when
type pain. So we're
I
talking.
think visceral, I think diffuse, I think spreading, because that smooth muscle is beginning to expand. When I think somatic, I think more what? Pinpoint.
So visceral is spread out. Somatic is pinpoint.
Yeah, like when you roll your ankle, right? And you're just damaging that tissue in your ankle. You get that kind of that deep pain in one spot, right? That's a somatic type pain. When you start getting to visceral, think about like your visceral tissue, like how it's encompassing an entire area. That's a diffuse type pain. Another way to kind of think about it is, your somatic, more musculoskeletal, your visceral, more organ, more abdomen, which is kind of where we say, somatic, when you hurt a bone, it's more pinpoint, right? That's a somatic pain. When you've got an abdominal situation, because of the inflammation of that tissue of that organ, it becomes more diffuse. That's your visceral pain. Here's a question you guys should all be able to answer. Which cranial nerve is sense of smell?
Olfactory.
There we go. What about the ability to shrug your shoulders?
Number 11.
What's the name?
I don't know.
It's your accessory.
Damn it. I gotta remember the stupid acronym. Somehow my truck broke down on the side of the road and my family sucks.
What is the primary hormone of your sympathetic nervous system?
Sympathetic or parasympathetic?
Sympathetic,
I think it's adrenaline.
which is epinephrine. Good. So how does a patient generally present when their sympathetic nervous system is kicking into play? What do their pupils do?
Dilate.
They dilate, right, to allow more light in, right? What's their heart rate do?
It goes up.
Okay.
They're in the fight mode.
Yep. And then what's their vessels do?
Constrict, pushing more blood towards the organs.
Correct. And what do their tissues do? Sweat. They